Hello, and welcome to the RX Hope Table Talks, session number 12. Data, 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 and here comes the evidence. This session is being recorded. My name is Leah Myers, and I serve as the Executive Director for the Families SCN2A Foundation. We are so excited to be bringing this virtual educational experience to the global community. During these sessions, the families and caregivers of the patients with SCN2A related disorders will be referred to as the experts, and the presenters will be the professionals. The goal of the virtual table talks is to allow experts, us, the parents, unprecedented access to professional researchers and clinicians working diligently to find a cure for our children. This is meant to be a casual environment, and your questions and comments are encouraged, as we're all here to learn from one another. To keep things running smoothly, please keep your audio on mute. And you can keep your video on if you'd like to. We'd love to see you. Use the reactions button on the bottom to raise your hand if you'd like to ask a question or make a comment, or you can send the question through the chat. Once the presentation is over, you're welcome to unmute yourself and ask questions. We don't have a large group, so it should be pretty easy to just start talking. If you haven't already, please introduce yourself and your child in the chat. Like perhaps their name, age, how SCN2A presents, for example, autism, epilepsy, or both, or something entirely different, and where you live. So I now have the pleasure to hand this over to a longtime friend of the foundation, Dr. Ann Berg, an esteemed epidemiologist from Chicago. Take it away, Ann.
Okay. Well, thank you so much for that introduction, Leah. Are my slides showing okay for everyone? Yeah, okay. Well, it's wonderful to be back with Families SCN2A. And about a year ago, we talked about the beginnings of a clinical trial readiness study. And today what I'd like to do is tell you more about that and what we're doing, because you are making this happen. So the reason for doing this trial, the study, is very important. Usually we think about seizures as the goal for clinical trials in something like SCN2A or other forms of epilepsy. But as you all know, SCN2A associated disorders are far more than seizures alone, and they include severe to profound impairments in neuromuscular function, autonomic system dysfunction, cognitive disorders, communication, sleep, behavior, GI, the list goes on. Basically anything that is touched by the nervous system can be dysregulated in a disorder such as this. We're now at in the era of precision medicine, where we talk about actually treating the disease and not just suppressing individual symptoms. We're not looking just for a seizure medication anymore. Those trials of new medications are coming, and we have to be sure that we're ready to measure the outcomes effectively. And this is really critical. You can say, why do I care? If the drug works for my child, great. But here's the thing, you will never get that drug until it is approved. And in order to be approved, it goes through a very rigorous process, which ultimately requires testing the drug in humans, in your children. And those tests are called randomized trials. And I won't go through the whole design, except to say that children or patients would be randomized, kind of a coin flip, either to get the new test therapy or standard treatment or placebo. And they would be followed and their outcomes compared to see if those who got the new therapy do better in some sense than those who don't. An analysis will be done, and if that analysis supports efficacy, that's great. You can take those data to the FDA, and if everything else is in line, the drug may be approved, and it now becomes available to your child and others. But what happens if that analysis fails to show that the drug was effective? You don't get approved. And this is not a theoretical concern. This is exactly what happened in the argaclifin trial for Fragile X syndrome. This was a drug intended to be beneficial for neurobehavioral function. And in that study, the investigators focused as their primary outcome on the irritability scale from a measure called the Aberrant Behavior Checklist. And if you're familiar with p-values, your eyes should come over here, and you should realize that this is well above the 0.05 limit. There's basically no impact of the drug on this outcome. And the other secondary outcomes did not show a lot of effect either. However, In a post hoc analysis, the investigators found that the social avoidance scale on the aberrant behavior checklist actually had a pretty robust effect. But this was a secondary analysis, post hoc rather, and the FDA said no. The authors, who are very talented neurobehavioral investigators, pointed out that their selection of the ABC irritability scale was driven by a US FDA precedent. The FDA knew the scale. They said, use this for behavioral outcome. And they reflected that their failure to find an effect could be because of a mistaken choice of endpoint or true lack of drug effect. And we'll never know from this study. Around the same time as that trial came out, the FDA started issuing its guidances to drug companies interested in developing drugs for rare diseases. And they pointed out the importance of identifying the full range of disease manifestations, understanding how they changed over time, the natural history. They pointed out the importance of selecting endpoints for trials that were important to patients, things that are life-limiting or life-altering, and you have to formulate a sensitive clinical endpoint. And that's what we're trying to do. These are your data from the SCN2A community, from the Simon Searchlight project. And those that many of you participated, you know, a lot of information was collected. And in 64 patients with SCN2A mutations, information about the Vineland adaptive behavior scales, number 2, was collected. This is a common measure. It's an old measure, though. We don't use it anymore, or very rarely. But it's scaled just like an IQ test, a mean of 100, standard deviation of 15. And what these scores reflect in the mid-50s is performance that is 3 or more standard deviations below the mean. Just to emphasize this in review, if we measure anything in the population, it tends to follow a normal distribution. There's an average. And then there's variability around that average. And we capture that variability with a statistic called the standard deviation. And in a distribution like this, about 2/3 of us fall within 1 standard deviation of the mean, average. 95.4% fall within 2 standard deviations of the mean. And we would call this group low and high average. And then 99.7% fall within 3 standard deviations of the mean, below average, well below average, and well above average. Only about 0.3% of the population falls less than or more than 3 standard deviation from the mean. Less than would be about 1.5 per 1,000 people in the population. These instruments are designed to break people up into average, above, or below average, way above, way below average. But once you get down here, it's very descriptive, and the range is really more theoretical than actually quantitative. The purpose, and it's very hard to distinguish when you get down there, the purpose of the CTRS is to identify key non-seizure outcomes for young people with SCN2A DEE, what's life-altering, select and measure trial measures of these outcomes and get their properties. Do we have floor and ceiling effects? Is that everyone is scoring at the very bottom or the very top of the scale? That's not helpful. Is there variation within the group? If I ask you a set of questions one day and repeat the questions a week later, are you able to tell me pretty much the same thing? Do different measures of the same construct converge? Are we getting the same answer when we look at the problem from different perspectives? How do the measures change over time? And are they sensitive to important disease or patient features? And very importantly, we need to get this information out to the scientific community and the FDA so there's a basis for using these measures. In conjunction with your parent board and scientific advisory board, we have really focused on communication, motor, and behavior as primary outcomes, and secondarily, we have some other medical outcomes as well. The design of the study, and many of you have already taken part in this, is that there's an initial assessment, which involves a fairly lengthy interview with a research coordinator, and then you go ahead and fill out forms yourself online. There's a 2-week check-in, a 2-week test retest where we repeat some of the forms. to check their reliability over a brief period of time. There's a 3-month check-in just to see how things are going and stay in touch. 6 months later, we repeat all of the assessments from baseline, a 9-month check-in to stay in touch, and then at 12 months, we repeat them all again. And some of these are clinical assessments, and we will provide you with the reports at the end of the study. And if you absolutely need them for clinical purposes, we'll work with you to get them to you or to your provider. We have a wonderful team, including the clinical psychologist, Eric Anderson, pediatric neurologist, Keith Kaufman, and the psychometrician, Aaron Cott. And in addition, Jerry Nesbitt, without whom this study would not be possible because he manages this amazing cloud-based platform that allows us to do this work around the world. We have 3 fantastic clinical interviewers, Lindsay Evans, Abby Van Newland, who's with us today on the call, and I hope to introduce you to her later, and Enrique Rojas. And many of you have met these people, and if you'd like to meet them, you haven't yet, join the study, and you will, I guarantee it. To be in the CTRS, we do require that your child have a pathogenic or likely pathogenic mutation in the SCN2A gene. And that's why we ask for your variants and for the report. It's really, really critical for scientific purposes. We started off with an age range of 1 to 25 years. We've modified that recently to include older adults. We also initially required that children have epilepsy, but we've also modified that to include children without epilepsy, but who have autism with developmental delay or intellectual disability. We also originally were only focused on the US, UK, Canada, and Ireland for a variety of pragmatic reasons, but people have spoken up around the world. The entire state of Israel has joined. We have people throughout Europe, South America, and Australia. We're thrilled that this has gone worldwide. And in addition, we do have a global one-time study, survey rather, that includes pretty much anyone else. And probably the biggest limitation is English language. You really do have to be English proficient in order to participate in the study. But if you can read and complete the forms in English, you can also do the global study. I want to acknowledge our partners who have been very helpful in interpreting variants. Dee McKnight, who's a clinical molecular geneticist, Dennis Walls and Eduardo Perez Palma, who are informaticists, and Al George, who has been sharing functional data on some of your variants with us. I want to tell you what we're finding from your study. There's been a lot of interest, 453 website hits on our screening form. 215 of you have expressed interest in either the CTRS or the global survey. And currently we have 55 who have initiated the global survey, the CTRS, and 20 have started the global survey. For the CTRS, initiating means completing the Vineland. Of those who have completed the Vineland, 45 have gone on to start the baseline assessments, and 37 have completed the baseline, absolutely completed it. 24 have gone on to do the 2-week retest, and 19 have completed the 3-month check-in, and we have a couple coming up for 6-month assessments in October. We have had responses from around the world. About 2/3 of our group come from the US and Canada. That's to be expected. We're delighted to have people from Colombia, Brazil, Spain, Ireland, and the UK, of course, were part of our original CTRS countries, but we have the Netherlands, Germany, Ukraine, Slovenia, and Georgia as well. From India, most recently Australia, and Israel. The SCN2A community in Israel rose up and said with one voice, we want to help, and you have been wonderful. Several of you have participated already. Each one is precious. So toda rabah for your report, your support, and know that you have ours. Am Yisrael Chai. The very preliminary results I'm going to share with you are based on both the CTRS and the global participants together, 65 of them. A little bit less than half are girls, or female. The median age is about 6 years. Half are older, half are younger, but half of the entire group falls between the ages of 3 and 10. You can see from the pie diagram, it's a very young group. Most of you are under 10 years of age, some under a year of age, about a quarter, 2 to 4, and about a third, 5 to 9. And then a smaller number of adolescents and a couple of adults as well. And you are all welcome to the study, so don't hesitate based on age. 55 children have epilepsy. For 7, it's clear that they do not, and 3, it's just not clear if they do or don't have epilepsy, and that happens in a disease like SCN2A. We see a lot of children with infantile spasms, Ohtahara syndrome, Lennox-Gastaut syndrome, and a few also with ESUS. The age at seizure onset is by and large very, very young. About 40% in the orange part of the pie diagram have onset under a month of age, most of that in the first week of life. We have another quarter in the first year, 1 to 11 months, another proportion in the second year, and a relatively small number who have seizure onset after 2 years of age. In terms of basic functional compass and compass points, this is really important to me just to sort of scale, to get a landscape of where children are. I'd like to know how many can walk. 38% of you said that your children cannot walk even a short distance, 5 yards. 42% do not manipulate objects well with their hands. 78% inconsistently, if at all, communicate with caregivers. 31% have a feeding tube, and 22% are completely dependent on G-tube for their nutrition. Related to that, 46% are mostly or completely dependent on someone else to feed them. Of those 3 and older, 92% are not fully independent for toileting needs, and that includes 62% who are completely dependent, who could not even help at all. How does that level of impairment translate into a score? Something that you could measure over time. Well, one of the instruments that we've been using in the CTRS is called the ABAS. And the ABAS is actually for children 0 up to their 0 years from birth up to their 6th birthday, 72 months. And the ABAS can give us age equivalence. And that means it can say, well, if your child can do this much, but can't do this, that's kind of like what you'd expect from a 2-year-old or a 3-year-old, an age equivalent. And what you can see here, these are the age equivalents from 0 to 72 months, and these are the chronological ages of the children in the study. The age equivalents are very low. For communication, it's an age equivalent of about 9 months. And you can see this one 10-year-old who's fairly high is at about a 4-year-old level. Socialization, same thing, age equivalent under a year, about 11 months. One child who's up around 5 years. And for motor, again, same thing, age equivalent is 11 months. Very low levels of functioning, but we can measure them. Another measure that we used in this study is the Vineland-3. This is not the Vineland-2, it's quite different. But like the Vineland-2, it has a mean of 100 and standard deviation of 15. And these are your children's scores from that Vineland. So this is the mean. And you can see everyone is well below that. We talked about that normal distribution. Here it is on its side, so we can put it all together. 60% within 1 standard deviation, 95.4% within 2 standard deviations. Here are the 2 standard deviations, and you can see only 1 child is falling in that range. If we go out to 3 standard deviations, there are a few. This is 99.7% of what we see in the general population. Only 1.5 per thousand. 4 standard deviations below the mean, that's about 0.5 per thousand. And we even have children measuring out at -5 standard deviations below the mean. We see that in approximately less than 1 per million in the population. SCN2A-DEE is a rare disease, but its outcomes are really rare too. We can't really measure with these instruments that I've been showing you what's going on at -3, -4, and -5 standard deviations below the mean. Those are theoretical measurements, they're mathematical constructs. How do we measure it, and how can we measure if things have changed in a meaningful way? So here's another measure. These are, again, your children's data from a measure of communication. And what you can see, a little bit different. The mean is 15, standard deviation of 3. So here's the population mean, and here are 2 standard deviations from the mean. And you can see that many of the children are not even getting off the floor. This is a floor effect. They are scoring at the very bottom of the scale. Not very helpful if we're interested in understanding this disorder. It's a little bit like imagining that someone throws a bunch of drops on the floor, a bunch of drops of water, and you're looking at them from where you're standing. It's like, well, they all look the same to me, and they're all the way down there. There's no difference. But if we had the right instrument, and we could with drops of water, we might start to appreciate that there's tremendous variability within each of those drops, and that's what we're looking for. And I think we may have found it. These are more data from your children. These blue dots are the same ones I just showed you, but now we're on a different scale. We magnified things. And these orange reddish dots represent another measure. And what you can see is suddenly within these dots that were way down here, no difference at all, we're starting to see a lot of variability. So we're starting to get a handle on that special instrument that we need in order to appreciate what is really going on in children with SCN2A DEE. The study is still enrolling. We are still recruiting. We're so grateful for those of you who have already participated. Please continue if you have not had an opportunity to, if you've been unsure, please consider enrolling in this study. We are starting to get answers that you need to be ready for those clinical trials that are coming. To enroll, just go to scn2a.study. There's a brief screening questionnaire. Please provide your child's variant. It comes in all different shapes and forms. What we're really looking for is something that says C dot, a number, and then something like G to A or T to C, or P dot, and then there will be a letter, a number, and a letter. They may look a little bit different. You might see an asterisk. You might see something that says FS. There might be some other things in there, but it sort of looks like that. Or whatever you have, please let us know. And really, the best thing, if you could do it, is upload a copy of your genetic test report. We have a completely secure server. If you don't have time to de-identify it, we will de-identify it for you. If you have any questions at all, we have a dedicated email address. What is epilepsy? @lurychildrens.org, or you can reach out and communicate with Abby directly at her address, avanewland@lurychildrens.org. And I know if you have any questions, you can always reach out to Leah Schuss at scn2a.org. Also, if you're interested, I know you're not going to capture this immediately, but if you are interested, you can go to our website, and let me see if this will work. You can see some preliminary results from your participation already. And you can see all about medical history, autonomic and sleep, basic functions, daily living, seizure types. We'd love to have you though as part of this database and have you participate as well. So with that, I think I'll stop. And can we just very briefly bring Abby on so people can meet Abby? Abby is one of our interviewers. She's also our project manager, and she manages so many aspects of the study. Big thank you, Abby, for all that you've done. Right.
That was great. Thank you so much, Dr. Berg and Abby, for everything you're doing. We are getting so much feedback on this CTRS from multiple researchers and industry groups that this is so important and just what they need to move forward with clinical trials. And thank you to the families who have already completed their steps to being enrolled and completely up to date. If you haven't yet, go in and just make the time. I know it's really hard, believe me. I put mine off and procrastinated for a while, and then I just said, okay, Friday in between 12 and 2, I'm going to sit down and do it. Sometimes if you just schedule it, you can get it done. I'm going to stop talking and ask for questions. Feel free to unmute yourself or raise your hand or put a question in the chat. This is your opportunity to ask questions directly to our professionals. got a quiet group. I think it's lunchtime. I do have a question that came up in online, and I think that I already asked you about it, Dr. Berg, but I'm just going to ask again for the sake of everybody else. A lot of people are very interested to see which medications work for different seizure types or for different function, let's say likely gain of function or likely loss of function. And they're hoping to see that come out of this. Just as a, not to guide them clinically, but just to give them an idea of who's responded to what. Do you think that's something that we could share?
Yeah, and I think we did take an early look at that, and we can certainly update that. But we do, as part of the epilepsy history portion of this project, ask you about which drugs your child has been on, if your child is still on them, what the impact on seizures has been, and if your child has stopped, the reason for stopping. And so some of the drugs are not used all that commonly, but we have a lot of information about levetiracetam, carbamazepine, phenytoin, and we're starting to get more and more about CBD. So we certainly do have that. In terms of for which seizure types, not clear, because we just asked overall, what was the impact for all seizures together. But if we are able to pursue our collaboration with the George Lab at Northwestern, we will have information about variants, and I'm very hopeful that we will be able to give you that information, which drugs seem to work with loss versus gain of function of variants.
Yeah, that's really exciting. Dr. Al George did comment on one of our table talks that he's committed to prioritizing variants that are enrolled in the CTRS. And that's exciting to get a functional analysis of your variant. Does anyone else have any questions related to the data or the importance of the data?
There's a question in the chat.
Oh yeah, that's a good one. Has anything been really
surprising? So one of the complications of severe developmental epileptic encephalopathies that has really caught my attention has been the involvement of the autonomic nervous system. And so much of the time we talk about this in terms of epilepsy, and people go see an epileptologist, and the epileptologists are highly trained specialists. They're amazing, but the nervous system is pretty complicated, and different specialists specialize in different aspects of it. So all the dysautonomia, it's it's there, but it's not really clear what to do about it, and it doesn't become front and center yet. Many of these children, and it's SCN2A, it's other disorders as well, have a huge burden of dysautonomic symptoms. And I was really amazed what we found with the SCN2A group. I wonder if I can just briefly share my screen again. Is that okay? Here's our infographic. Are you seeing the infographic? Yeah. And this is just an infographic, but 82% of parents reported one or more autonomic symptoms, and the median number of autonomic symptoms was 5. And it includes things like temperature dysregulation, problems in sweating, too much sweating, too little sweating, sweaty palms, that sort of thing, a lot of reflux and vomiting, high pain tolerance in this group. 53% reported high pain tolerance, which is phenomenal. And that's kind of scary too, because it means that children don't know when they've hurt themselves. And I've seen that, the child broke his leg and didn't realize he was limping, and his parents didn't know why he was limping. And it turned out he had broken his leg when he fell during a seizure. The abnormal pupil dilation, contraction, gastrointestinal, and I know Scotty Sims is on the call. This is a huge issue in the KCNQ2 community, but also urinary retention. And that can be very serious. That can cause kidney problems. And then excessive irritability, which I hadn't really thought of as a dysautonomia, but thanks to Dr. Kaufman, who's on your medical advisory board and who helped design the dysautonomia questionnaire, we now include that as one of the dysautonomic symptoms. And 13% of you your children had autonomic storms just in the past 3 months. So this is clearly a huge piece of SCN2A.
It's nice to see the numbers because we definitely see it in our online discussion page on Facebook. It's so highly reported, and most clinicians don't diagnose it that way. They think the symptoms have another cause, but looking at it like this, it's very clear that many of these are due to autonomic dysfunction. It's nice to see that that in black and white here.
Yeah, and this is the kind of thing you can take it to your physicians and say, look, we've done community surveys and almost all of our children have these issues. And I think we don't know yet, but as I said, anything that's regulated by the nervous system can be dysregulated in something like SCN2A DEE or KCNQ2 for that matter.
Thank you. Carla, do you want to ask your question?
Yes, with other registries that are out there, like the Simon Searchlight and other things, we know that the CTRS is open and sharing that data. So how do you see that data helping the CTRS and vice versa? And which registries are already reaching out to you to share that data?
To share the CTRS data with others, or
yes, and vice versa.
We have not. So one thing, and it was something that Leah and you and your board really emphasized was important, was that whatever data we collect be made available to the scientific community. It's not my data, it's your data. So, in the past, IRBs have been, the institutional review boards, the ethics boards that monitor research, have been a little difficult to work with. But what we learned, and I give Abby tons of credit for this, is that if you just state what it is in your consent form that you're agreeing to, and you agree to it, and it's nothing terrible, but to share data, de-identified data, or identified even, as long as you've agreed to do that, it's okay. And the IRB allows us to do that. We're very careful to be upfront and say exactly what we're doing, but as long as we do that and you agree as your child's adult guardian, it's okay. So we are prepared to do that. We would like to get the data in good shape and published first so that it is out there before the FDA. That's going to be really critical. But we're hoping to do that as quickly as possible. And then we'd like these data to be available to Simons, that we have actually an agreement with Simons where you can tell us, I want you to share my data from the CTRS with Simons in such a way that they can link my child's data with in the CTRS with my child's data in Simons. And we're hoping that will become something more universal. I mentioned my colleague, Jerry Nesbitt, who runs, he's the one who runs these websites. It's an extraordinary, complicated thing that he does because it is ultra secure. It's HIPAA secure. It meets all European GDPR requirements. We're really tight on security. He knows how to do that. And he's also come up with a way that basically it's a system that will allow the individual patient or parent to provide access to his or her data across multiple data sets, that the parent or the patient has that control, rather than having to go to the IRB and have data use agreements and all kinds of complicated things. It gives you control of your own data. So we're just on the threshold of that, but it's very exciting to see it happen. And we're hoping that will become the norm rather than the one-off.
It's very exciting. I'm speaking on behalf of me and so many families that I've talked to. I think it's going to cut down on duplicating have our efforts. You know, we feel like we're always being asked to fill out surveys and questionnaires, and many people are like, I know, you know, they just need it in a certain format, so I have to do it this way, and they just do it because they want to contribute, they want to keep things moving forward. But others get frustrated, you know, they don't want to do the Vineland 6 times in 1 year, and you know, it would be really great if they could somehow connect those. So thank you so much for the efforts you've put forward to make that happen for us.
Well, I think SCN2A is really it has a big footprint for me in changing how this kind of rare disease research is done. And that for SCN2A, but for others, you're sort of at the lead right now, but I think others will follow. And I think you know, that Terry Jo Bichel at Combined Brain is trying to work with Jerry Nesbitt to make this available across rare diseases. So it's really a movement. And you started it. You helped start it.
Terry Jo, you know, she represents several different groups that are under, like, I think there's like 17 or 20 groups there, and they all struggle with the same thing, you know, trying to connect data and reduce silos. So I can't think of a better team to work on it than you and Terry Jo and Jerry. Jerry's fantastic. I have one more question. It's about measurements, and you have done such a great job of explaining why choosing the right measurements before you start a clinical trial is so important to the success of the clinical trial. But we hear a lot about new measurements coming out, like an ORCA is a new one that's coming out, and I can't even remember them all, NET and some different ones that are new, and they're trying it in different disease groups. How does the FDA look upon those versus what we're doing with using already validated, proven measurements?
That's a really good question. The answer is I don't know. I'm actually glad that we're using the tried and true measurements and modifying how they're, in some cases, we're having to modify how they're administered. Abby can tell you all about that, but we have weekly meetings and we talk about how do we apply the Vineland criteria in this situation, and that's what Dr. Anderson oversees. We have some alternative ways of scoring them. But what I like is that the FDA is familiar with these instruments, the community is familiar with these instruments, and right now we're demonstrating how those instruments work in your community. I don't know what's going to happen with an entirely new instrument. It would be great if we had a yet better instrument, but I just don't know how that's going to work. I do know that sometimes those instruments are amazing. The Batten disease group has their own outcome, their clinical trial outcome, which allowed them not only to do an effective trial, but to use natural history controls as their control group. That's an ultra rare disorder, and they only had 24 actively treated patients. That was a major, major success. The Rett syndrome group has developed their own outcome measure, and it's not worked as well. So we'll have to see what happens with the ORCA. There's a lot. There's some risk in making up a new instrument. We'll see.
I know that you're right. We do need more sensitive measurements. But am I right in thinking that it's just going to take a little bit longer? FDA is not going to recognize them right away. They're going to have to take some time to be validated. Or do you think we'll go right into using them in clinical trials like now?
Well, I think with the instruments that we're using, because they already are standardized, at least in the general population, and validated, and that now we're doing additional validation within the SCN2A community, I think that will make it much, much more palatable. There's a little bit more validation we can do, and we talked about that. It will be an additional piece to the study, but it is possible to do that. And that would involve actual clinical assessments. We're focused on parent-reported outcome measures, but we could do some clinical assessments as well in a limited number of patients. And that would probably be the cherry on top.
Thank you. Does anyone else have any questions? Anybody want to ask anything? Abby, would you mind telling us a little bit, because I know that you've been like up to here in Vineland, a little bit more about like the difference between like the old Vineland that many of us did in Simons and the new Vineland, and what lessons you've learned?
You know, I don't know anything about the Vineland 2. I do know they updated the answer choices. So we're looking at if, say if I ask you about like toilet training and like how often your child will tell you if they've like wet themselves. Your options are often, sometimes, or never. And I know it used to be always, sometimes, or never. I know that was one of the biggest differences that we talked about when we were training. And for us, the people who are scoring it and talking with you, sometimes it's the difference between the often and the sometimes that will really catch us up. Is this something, you know, is this something you're doing 90% of the time, or something you're only doing like 50% of the time? And for us, that's often can be a difficult distinction to make, especially when we're involving, you know, like a oh, I can't remember what it's called, the packs for like communication, those sorts of things, or different mobility devices. Sometimes that can throw a wrench into it, and we kind of will wind ourselves into this mental puzzle of, oh, is this something they're doing often without prompting, or sometimes it can be difficult.
Yeah. I think for me, one of the biggest differences is that the Vineland 2, as Abby said, it has greater granularity in the lower ages. I think that's what you were indicating. You can make distinctions, finer grained distinctions at skills that are appropriate for younger ages. But also, I think the Vineland 2 is just used as a parent reported form. Were you actually interviewed for the Vineland by Simons? You just filled out a form. So it's more of a parent checklist. Whereas the Vineland 3 is a clinical interview, and it's done by people who are trained and supervised by a clinical psychologist, and that's what Dr. Anderson does for us. And it's done in a very thorough, rigorous manner. So it's if the parent's not understanding something, the interviewer can catch that and make sure that the answers are being given in a reliable, as valid a way as possible. So I think it's just a much more reliable, much more accurate assessment. It is harder to do. It takes more time, as you know, but it's really giving us, I think, very clear data.
As a parent, I find it easier. Like when Lindsay interviewed me to do the Vineland, I found it much easier because she did help me to understand and make that differential between often and always, which you're right, is really hard because our kids rarely do anything always. You know, it depends. So often that's really helpful that that's now an option. Has anyone got the Vineland and would like to comment on their experience?
So I can comment on the Vineland. Leah knows this, and you'll find this interesting, is our daughter, who doesn't have SCN2A, has KCNQ2 for transparency, over the quarantine had profound cognitive growth. She went from being very, very limited to she learned her alphabet phonetically, the order of letters. She learned her numbers 1 through 20, can put them in sequential order, learned all her animals, her colors, so much academic growth. It was just unbelievable and blew us all away. And it came time to do the Vineland, and I was so excited, and I filled it out, and then I compared it to the Vineland I had done 18 months before, and she only went up 1 spot in 1 little bubble. And it was a gut punch.
Oh.
So that's my just personal experience with the Vineland and how it really does not in any way, shape, or form capture our children at all.
That is unfortunate. I am thrilled that Harper is doing that. Let me just say that is phenomenal. I mean, go Harper. That's great.
Right.
The Vineland, it's not a cognitive test, and that's something we have to keep in mind.
Mm-hmm.
It's what we call adaptive behavior, and that's how we get along in our environment. And it's based on cognition. I mean,
Right.
you have to have a certain level of cognitive skills and understanding in order to get along in your environment, but then it's how you use those skills in the environment. So we have to be really careful, not pretend that what we're measuring is cognition. If she had been given, say, the Mullins, which is a cognitive test, you would have seen that growth. And the two, are going to be very correlated, but there are ways in which they diverge. So I'm sorry you had that experience. It must be very frustrating. Was it a parent reported that you just checked it out and filled it out yourself?
Yeah.
Yeah, and that could be part of it too. I think if you, I can't guarantee, but maybe Abby, you could comment on it. You know the content inside out. But I think if you had done the interviewer form, the interviewer probably would have probed a little bit more, and you would have seen some greater growth with that score, with the clinical interview than just the parent checklist.
I know in some sections they do ask about things like identifying letters of the alphabet and identifying like your name written out and those sorts of questions, but that's only in one section. And so I think I agree with you that it's definitely not a cognitive assessment. It's more of your adaptive behaviors, but recognizing alphabet letters is an adaptive behavior to a certain point. Mm-hmm.
Scotty, the other thing too is that, were you just looking at standardized scores?
I mean, I was only filling this out because I detest the Vineland because it just takes so long to do, as all parents understand, but this is just insurance requirement. So it wasn't even really anything that I was that concerned about, just because I knew it wasn't going to capture, our daughter. And so I really wasn't even paying that much attention, other than she had this growth, and I was hoping it would reflect even just minutely, but more than one little bubble.
Yeah. So what happens too is the Vineland, if it's being done for insurance purposes, you're getting a standardized score, standardized to 100, mean of 100, standard deviation of 15. Okay. And at her age, and this is seen time and time again. Don't know if I can quickly pull. No, it's going to take me too long. But what happens with standardized scores in the SCN2A population, and we showed this, actually I showed it a little bit in my slides, but we showed this with the Vineland 2 in particular, those standardized scores actually go down over time because children are not keeping up with their peers. Their peers are gaining skills at a certain rate, and they may be gaining skills, but they're still falling off, falling off a growth curve. Like head circumference. If a child's weight or head circumference stays the same over time, he falls off the curve, right? Because he should be gaining at a certain rate. It's the same thing with skills. If we had looked at Harper's raw score, then you would have seen that growth. And that's what we did with the Simon's data before. We looked at the standardized scores, which all drop over time with age, and the raw scores, which all go up. So it's how you look at that. And that's part of what we're learning how to do, is to look at alternate ways of exploring these data to show the growth.
And that's published, I think, Scotty, I sent it to you a while back, but it's on the website too. Dr. Berg published that data showing the Vineland 2 is really, it was using that standardized scoring as a poor measurement for our kids. We all know that. And actually, when we were designing the CTRS, I begged not to use it. But one of our scientific advisors, who's very well known in is she a psychologist, a neuropsychologist?
She's a neurologist.
Okay.
Yeah.
She's like, we really need to use it. FDA loves it, but don't use it in that format, because you're right, it's not going to work that way. Use it like this, do the Vineland 3, do it interview style, use raw scores. And I think that Abby and Dr. Berg can agree that it's very different than what we saw from the Simons data, what we're seeing now in the CTRS. It would be interesting to have you fill it out this way, just to see how different it is, you know. But yeah, mentioned, that's what we're doing. We're trying to figure out which measurements don't show change in our kids, and which ones do. So that was spot on. Thanks for sharing that.
Yeah. And great for Harper. That's so exciting.
I know with my experience with my son, there's some of the testings that don't allow supports so to be included. So that was one thing that he always declined in. So there's maybe certain things that he could do, but he needed certain supports to do it, whether it's an equipment or something. But they would say, no, he can't do it because he needs support. So doing it this way actually helped really figure out how well he can do in certain areas with support.
Right. And, you know, I just want to pick up on that, Carla, depending, it sounds like this might have been like for school, for an IEP, to get services. They want to be able to say he needs support, because then if he can do it by himself, then he doesn't need services to help with that. So that's important. And I know it's painful. You could say, oh, but he can do it, you know, if he's got some support. But they need to say he can't do it independently. He needs support. He needs help, and that helps justify.
Yes, and it wasn't just school too. It was also in like with Simons and things. There were certain answers that it was either black and white. So it's interesting how they're both different.
Yeah. Yeah.
Does anybody want to ask any more questions? Anybody need some motivation to finish their baseline surveys or schedule your interview? Is anybody having communication issues? Please feel free to reach out to us and we'll connect you. Sometimes stuff goes into your junk folder. We've seen that happen. So you might be waiting on an email reply and it's in your junk folder. I'm very guilty of that. Okay, well, this was a wonderful session. I think I might close it up unless anybody has anything else to say. Okay, so amazing session. Thank you so much, Dr. Berg and Abby, for volunteering your time to help us understand this. It's really exciting work, and we are so happy to be clinical trial ready, as we're all very excited about clinical trials coming our way. Thank you to the families who joined us today. Your questions and comments were very helpful. If you're like me, you're going to think about this later and maybe in a few days and come up with some more questions. As always, the volunteers and staff at the foundation are here for you. You can reach out to us, send us questions. We'll do our best to get them answered for you right away. There is one more table talk in the RX Hope virtual series. It's a bonus session. It's going to be called Meet the Foundation and the Board, and your opportunity to ask us questions and get to know the board members. Be sure to register for that in advance. We're going to make these recordings available as soon as possible. And there is so much work still left to do, and we really need your help. One obvious area that you can get involved with right now is the SCN2A CQRS. If you haven't registered yet, do it right now. It's really super simple. Just go to scn2a.study and find out if you're eligible. You'll be invited via email. If you have been procrastinating on scheduling your phone interview or finishing your baseline surveys, make the time. Just schedule the time and get it done. If you need any help from us, we're here for you. And one other way you can get involved is sign up for the SCN2A Warrior Challenge. It's a virtual walk that we do every year. This is our third one, and Carla will put some links to that in the last 20 seconds of the recording, I think, right, Carla? Okay, awesome. Thank you all so much. Have a great rest of your week.